and may have never met anyone. But we know that about 1 in 26 people have a diagnosis of epilepsy. So it is actually a pretty common disease, and pretty commonly, as you can see here, that there's lots of kids who are also affected with epilepsy. In a class of about 1,000 students, there will be 6 who have epilepsy. There's about 450,000 children with epilepsy in the United States. So one of the things that also is really challenging with a new diagnosis of epilepsy is trying to navigate the school system with somebody who, you're like, do they even know what I'm talking about? Have they ever seen anything like this before? And it's really common that the school system has dealt with other children with epilepsy before. And so trying to figure out how best to advocate for your child in this school system can be tricky, but they have seen other kids with epilepsy before. And I think today, once again, is a great example of how many children there are out there with epilepsy and are going through this at the same time. So first off, what is a seizure? So if we think of our brains as big computers with wires that are running from one place to another, and kind of all that information is passing back and forth all the time, a seizure is a short circuit in the brain. It's when all the electrical activity goes one place at one time. And even if we had an EEG hooked up, you can see that kind of everything moves the same place at the same time. And the symptoms from a seizure depend on where in your brain that activity happens. So some people can have seizures that abnormal activity is in the back of their brain, and they can start their seizure with visual hallucinations or changes in color. Other people can have seizures that start in areas where their motor function is, and they'll start off with kind of hand jerking as the first part of the seizure. So they can look very, very different depending on where it's coming from in the brain. So what is epilepsy? Epilepsy is a brain disorder that causes recurring seizures. The idea is that if I don't start some type of medication, the seizures are going to keep happening because you have a propensity towards having seizures. The tricky part is that it can be due to a lot of different causes. And so that's true where even if you have a new diagnosis of epilepsy and you know somebody else with epilepsy, it's very common that the stories are very different, the seizures are very different, the response to medication is very different, just because we know there's lots of different paths to get to a diagnosis of epilepsy. So you guys have probably all experienced this in terms of the typical evaluation for epilepsy and where we start. And so normally we start with kind of a thorough history and exam, an EEG, and then usually some type of brain imaging like an MRI. There's a few situations where we wouldn't need brain imaging, but most of the time we're going to end up getting an MRI of the brain. And I want to talk through each one of these in a little bit of detail. So in a history or exam, a lot of what we're trying to do is get as much information as we possibly can about the seizure or about what happened. I usually start with families and just tell them, I'm going to keep asking you questions until you say, I don't know. Because that way I know that I've gotten all the information that there is to get with regard to kind of how things started. So I'm usually trying to figure out what happened the night before, what was going on that morning, what's the first thing that you noticed at the onset of the seizure, what happened during the seizure, and how are things afterwards. And that's how I can start to understand a little bit more about what type of seizure occurred and why I think that it's happening. It can be really hard too because with a lot of people, the first time you see your kid have a seizure, it's a pretty traumatic experience. And so trying to get a family to relive this in clinic is never fun for anyone because they'll kind of go back and have to relive that process. But the reason why we make you do it is that it's really, really, really helpful to figure out what's going on. Next thing is I'm going to ask you if there's video associated with the seizure. We live in a time now where we have video on our phone that we can get really easily, but no parent's first thought when they see their child having a seizure is, I should get my phone out and record this. And even though everyone here already has a diagnosis of epilepsy, I think, it is really helpful if new things pop up, if there's episodes that are kind of confusing or different, and we're not sure whether they are or aren't seizure, if you're able to video it, it can help us kind of understand what's going on and what's new. And I would encourage you that if you are recording an event, most people are going to try and call their child's name, but if you can do other things like tap them on the forehead, try and pick them up, move them around, maybe give them a little tickle or a little pinch and see how they respond during that event, that's also going to be really helpful to me in terms of understanding what's going on. Because even though, if somebody has a diagnosis of epilepsy, some new event is more than likely to be seizure, we still want to make sure that we're not going to treat something else like seizure if there's some other mimic or something else that's going on. We also want to know, are there other health issues? So there's other things that can kind of masquerade or kind of mimic seizures. And so especially if you have lots of sleep problems, diabetes, sometimes endocrine issues can all lead to events of loss of consciousness or abnormal movements that someone can see that and think that it's a seizure, but it's actually something else that's going on. And we want to know that whether it is or isn't a seizure, because I don't want to use seizure medications to treat somebody's new onset diabetes. That's not going to be helpful. And then lastly, any abnormalities on the exam. So you've all seen kind of the neurologists do their extensive neurologic exam where we're kind of checking kind of how the eyes move, how the arms and legs move, the reflexes. And really what we're trying to figure out, is there one area of the brain that's not doing what it's supposed to be doing? Is it not working appropriately? And that can give us some clues in terms of where we think the seizure is coming from, or basically, do we think that we need to do more of an investigation for something that doesn't quite make sense? We're always trying to get all of our information to kind of paint one clear picture. And especially when I meet someone new and all the pieces don't fit together, I know that I have work to do to try to figure out why everything doesn't fit the way that it should. After we do the history and exam, most people are going to end up getting an EEG. So I think everyone here is familiar with EEG in terms of the brainwave test. We're going to stick the electrodes on your head and try and get a look at kind of what that electrical activity looks like. So we're really looking at kind of all those wires that are doing all the things they're doing all day long. And what we look for initially is, what does the background of the EEG look like? Because all of us have kind of normal electrical activity going on at all times. And so we want to make sure that your kind of background electrical activity looks the same as kind of other kids with electrical activity in their brain, because if it's a difference, that may give us some clues. Most of the time, we're not going to be able to capture a clear seizure on EEG, but we can see risk for seizure on the EEG. So we can see kind of like a frayed wire that's throwing off sparks and showing us that there's a risk for that short circuit. And you guys have probably heard this as like epileptiform discharges or spikes or sharps, and those will be in those EEG reports. And that's what we're referring to as kind of that frayed wire that's showing us that there's a risk for seizure. There's different types of EEG as well. So standardly, we'll usually start off with about a 40-minute study, and that's where you've probably been sleep deprived. We try to get you awake and asleep. We end up doing kind of flashing lights and also doing hyperventilation to try and kind of provoke the abnormal activity, because that'll give us some clues both to like what types of seizures you're at risk for, as well as kind of what's going on. Sometimes we also need to do longer studies, so there are ambulatory EEGs where we attach an EEG and then you kind of wear it home for a couple of days. And then there's other EEGs where we want to admit you to the hospital and you have to kind of stay with us in the hospital and be on video so we can capture everything while you're there. And there's somebody else today talking about EEG in detail, so I'm not going to belabor this one because you're going to get a whole lecture just on EEG a little bit later. MRI. So taking pictures of the brain is so that we can see the structure of the brain. If the EEG told us what functionally is going on, the MRI tells us, is there a change in the structure of the brain? And really what I'm looking for is there something in the brain that shouldn't be there, or is there something that should be there that isn't there? Most parents' first thought is brain tumor or something like that, and realistically, that's usually not what I find and not what I'm looking for. It's a lot more common that I find evidence of old injury to the brain, sometimes even from around the time of birth, that can cause a predisposed to seizures, or we can sometimes find basically malformation in the brain, where there's one area of the brain that didn't form exactly the way that it was supposed to, and when we see those malformations, that can also kind of predispose to seizures. So it is important to get the MRI in a lot of these cases, because sometimes that helps understand exactly why someone is having seizures or where they're coming from. And really what we're looking for on the MRI, and this is a picture of the MRI, is we kind of try to see, does the right side look like the left side and vice versa? And on this one, there's this little area right here that's kind of blurry and is well formed on this side. And this is an example of mesial temporal sclerosis, or kind of an area of scarring down in the brain in that area that commonly will generate seizures. Excuse me, sorry. So once we've done all of those tests, or sometimes when we first meet someone we can do this, we talk about what is a diagnosis of epilepsy. So epilepsy means that you've had more than one unprovoked seizure more than 24 hours apart. So if you kind of have a bunch of clusters in one day, we don't count that as kind of new onset seizure. There has to be some space between them. Additionally, if you have one unprovoked seizure and some other test that makes us think that you're likely to go on and have more seizures, we will call that epilepsy. So this would be like if you had a single seizure and then we got an EEG and we saw the EEG was abnormal, we'd say, oh, we think you're likely to go on and have more seizures in the future. So at that point, we may kind of move towards a diagnosis of epilepsy and starting medications. Same thing for if we see an abnormality on the MRI. But a lot of times when you get into that gray area of number 2, that's more of a discussion with the family in terms of what's your priority. Would you rather start a daily medication or wait and see if another seizure happens? And every neurologist and family kind of approaches that a little bit differently. And then lastly, diagnosis of an epilepsy syndrome. This is pretty rare, but there are a few pediatric epilepsies where if you just have one seizure and we see kind of some specific abnormality on the EEG, we can say, oh, you've got this type of epilepsy, and we have our answer just based on that criteria. But that isn't the most common. Most people are going to get diagnosed with epilepsy based on having more than one seizure, more than 24 hours apart. So, this is where things start to get tricky. So we start talking about different types of seizures and epilepsy. One of the problems is that neurologists love to rename things. So if you grew up and kind of know the names of seizures, those seizures no longer exist because we kind of changed the name of everything actually twice in the past 15 years or so. So things like grand mal seizures or petite mal seizures or complex focal seizures, we don't really use those anymore. We changed over to a whole new set of language. So if you start looking through your neurology notes, you'll see a lot of this language throughout the notes. So I'm going to try and go and break this down a little bit so you can kind of understand what we're talking about and how we put things in different categories. So the first thing that we try to figure out is, do we think this is a focal onset seizure or a generalized onset seizure? Because there's two main categories. Now, with a focal onset seizure, this is usually what most people are familiar with. So if you know someone who's had a stroke or who had a brain injury, or they had kind of one area of their brain that's generating seizures, that's a focal seizure. So there's kind of one spot that's kind of spreading to other places, and that's what we call focal seizure. The tricky part about this is that a focal seizure can look like me just having twitching or jerking of my arm, but it can also look like a full body kind of tonic-clonic seizure if it spreads really fast. So if you're just watching someone have a seizure and they just have a full body seizure, I won't know whether that's a focal seizure or whether that's a generalized seizure unless you can tell me that it really started with one symptom and then spread to the rest of the body. And this is one of the things that's most confusing because I have to use the EEG to help me in some of these scenarios to know whether it's focal or generalized. And it's really important that we know because we use different medications for different types of seizures. And if we don't know, we have to stick with big, broad, general medications. We can't kind of narrow it down a little bit more. This is an example where it can kind of spread to the other side even after it starts in one place. With a generalized seizure, we kind of get the whole brain lighting up at once. And so there's this kind of middle area of the brain called the thalamus that's kind of a way station for the brain where lots of information passes through. And what we find is that somebody who has generalized epilepsy kind of has the whole front of their brain or sometimes the whole back of their brain. But on EEG, we see kind of the whole thing light up all at once. It's not just spreading from one specific place. And normally in these situations, we think of this as somebody who has a genetic predisposition to epilepsy, but it's usually not something that we can understand by doing genetic testing. Like, it's not one gene that's the problem. We usually think that it's probably 4 or 5 genes that all kind of lined up in the wrong way. And this is where sometimes, where we say, oh, we think this is genetic, but you're like, well, no one else in the family has a seizure disorder, or has epilepsy. It may be that there's just kind of this little predisposition that runs through families. And what's interesting is that with generalized epilepsy or generalized seizures is that, let's say you have generalized epilepsy, if we did EEGs on other first-degree family members like mom, dad, or siblings, they're more likely to have abnormal EEGs and have never had a seizure in their entire life. So we know that there's some genetic component to it. We're just not smart enough to understand it yet. And you're going to get more talks about genetics later today, so I'm not going to spend tons of time on it because somebody else is going to go really in depth with it. But we are trying to learn a lot more about the genetics, especially of generalized epilepsy, that we don't understand very well. Okay, so now that we've said that we think we know kind of what a focal seizure is and a generalized seizure, we can actually start to break it down even further. So we just start to describe what do we see when the seizure starts. So with a focal seizure, we talk about, do we think that someone is aware or do they have impaired awareness? So is that somebody who has like facial jerking where then they can talk to you through it and they know what's going on? Or do their seizures start with them kind of being a little bit out of it at the beginning and confused? And then we move on to, is there a motor component to it, yes or no? And so we can start to describe these seizures and actually put them into nice categories based on what happened in that history that we took. Same thing for the generalized onset seizures, where we want to figure out basically, is there kind of full body movement or stiffening, or is it a non-motor seizure like an absence seizure where there's just staring and unresponsiveness? And then we can go even further than that and break it down to get even more descriptive. And this gets into kind of really, really kind of detailed with regard to kind of how we describe a seizure. And I don't want to kind of go through everything a ton, but I want to talk through these terms just because you've probably heard some of these at some point, and they're very much medical jargon that kind of gets lost. So with automatisms, that's something that we see really commonly in seizures. So at the beginning of a seizure, it's not unusual to see someone who has kind of like slight hand movements, or another common one is lip smacking, where they'll kind of do a, and so that we would describe as an automatism, where it's kind of a unconscious movement that you're doing at the beginning of the seizure. Atonic seizures are where you lose tone and you fall to the ground. Clonic seizures are going to be kind of continuous jerking of one part of the body. Epileptic spasms are usually going to occur in really young kids, but you're going to get a quick jerk and then a quick stiffen. And that's kind of different than myoclonic seizures, where usually it's just a quick jerk. Hyperkinetic seizures are pretty rare, but they're really unique when they do occur. A lot of times it'll be kind of thrashing coming out of sleep, or I've taken care of one kid where when he'd have his hyperkinetic seizures, he would kind of do this kind of like fumbling with his like drawstring on his pants, where he'd like kind of have really quick kind of abnormal movements at the beginning of the seizure. With non-motor onset, you can have kind of pretty much any type of sensation that your brain can generate can be at the beginning of a seizure. So with autonomic, there's some people who have nausea at the beginning of their seizures, or heart racing, or sometimes they get real pale at the beginning of their seizures. There's other people, like we talked about, have the behavioral arrest where they just kind of stop at the onset. And cognitive means that you can have symptoms like deja vu at the beginning of your seizure. So some people will describe that as the first sensation. Or a lot of times I'll have teenagers in particular who tell me, I don't know, it just feels weird. And that's kind of the best description that they can give me is how their seizures start. And no matter how much I try and put them in a box, they won't let me. And they just like, no, it's just weird. That's all I've got. And then emotional, so you can have people who have kind of anxiety or fear as the first sensation of their seizure. And that one's really hard because I've taken care of kids before where that's the first sensation, and they actually get misdiagnosed as anxiety and panic attacks for a really long time because no one's thinking of that as a symptom of a seizure. And then finally, sensory, which I mentioned earlier, where basically I took care of one child where his first part of his seizure is that he said the whole room would get a color of salmon. And he was really specific that it was salmon colored, where he'd get like a visual aura at the beginning of his seizure that everything would change color. And so you can get kind of these weird sensory components. I took care of one little girl as well who told me that she felt wet at the beginning of her seizure, as that was the first sensation she had, is she felt wet. So pretty much anything that your brain can generate can be the beginning of a seizure, and we try to put it in these categories so we can start trying to describe it consistently, meaning that if I'm in Ohio and describing a seizure, and someone's in LA describing a seizure, we're going to roughly use the same terminology. And then with generalized onset seizures, it's a lot of the same things that we already talked about. The generalized seizures kind of tend to mishmash the other terms together, and you can see they're just kind of stuck together. The ones that are a little bit different are typical or atypical absence, but that's more of just EEG findings. And then the last one is eyelid myoclonia, where typically you'll see kids who will do this kind of eye fluttering at the beginning of their seizures, where they'll do this kind of like, it'll almost make their eyelids flutter up right at the beginning, or they'll just do the eye fluttering and not a lot else. And then, once again, things fall into the unknown onset where we just don't know and all we can do is describe things. Okay. So we talked a little bit about all the different seizure types. So if I'm meeting you in clinic and I'm trying to figure out what's going on, I've asked you 100 questions and you're tired of me asking you questions about your child's seizure, but I've kind of in my mind put it in a category of, okay, do I think this is a focal onset seizure or do I think this is a generalized onset seizure? Then I can try to put it in a category and say, is this a focal epilepsy, a generalized epilepsy, combined, focal and generalized, or I still don't know which one it was. And so we can start trying to piece things together and understand what type of epilepsy somebody has, which once again is really helpful for me understanding what's the prognosis, what other workup do I need to do, what medication should I use. So it's kind of the way that my brain starts to try to put it in a category. The same way if you went to your doctor and you said, I have a cough, they're going to be trying to figure out, okay, do I think this is pneumonia? Do I think this is asthma? Do I think this is allergies? It's the same idea. It's just kind of with all the specific features of seizures and epilepsy. Once I can put something into an epilepsy type, then I'm going to go further and say, can I put it into an epilepsy syndrome? Because there are some very specific epilepsy syndromes that we know about. And not everybody fits nicely into one of these, but if we can get someone to fit into one of these categories, once again, I can give a little bit more information about prognosis and treatment and things like that. And epilepsy syndromes are things like Lennox-Gastaut syndrome or juvenile myoclonic epilepsy or childhood absence epilepsy, things that have been pretty well described and we understand pretty well. Once we've gone through all of this and I've kind of put it in a category and got a name for what's going on as best as I can, then I'm going to figure out why do I think that it's happening. And this is the hard part because I'm sure as many of you know, sometimes we just don't know. We don't have an explanation for why seizures happen sometimes, but we usually try to do our best to figure it out. So as far as the kind of the underlying etiology or cause of seizures, structural causes are going to be, like we talked about before, where there's some problem in the structure of the brain that predisposes you to seizures. Genetic is going to be where you've got some type of genetic change that makes it so that, like, if you go back and kind of remember how all that electrical activity is being conducted through the brain, if you have a genetic change that basically makes that electrical activity easier to conduct, that can also cause problems and make you more likely to have seizures. From an infectious standpoint, usually we're thinking about somebody who had meningitis a few years ago or something like that, where they've kind of got long-term injury to their brain from some type of infection. Metabolic is pretty rare, but there are some genetic conditions where your body can't use protein, glucose, kind of like fats appropriately, or there are some conditions where your body can't get sugar up to the brain to be able to power the brain the way that it's supposed to. Immune conditions are rare as well, but there are some immune conditions that can kind of predispose you to epilepsy. And then, like I said, unknown is a big category. Most of the time when we first meet someone, we're really thinking about, is this a structural etiology, or do they have some other features that kind of push us into one of those other categories? But this is where a lot of it is just that initial conversation and trying to figure out what do we think is going on. Okay. So now that we've gotten to the point where we've talked all about seizures, we've got our diagnosis of epilepsy, the question that every family wants to know is, are seizures dangerous? Because if you've watched your child have a seizure, it's probably one of the most helpless feelings you've ever had, where there's nothing that you can do and they're kind of in distress. So the things that I want to know in terms of trying to answer the question of are seizures dangerous is, one, are they frequent? So if someone's having lots of seizures, I get a little bit worried, mostly from the fact that, like, if you're supposed to be going to school, interacting with other kids, doing all the things that you want your child to do to kind of live a happy, healthy, kind of enriched life, all of a sudden if they're having lots of seizures, they aren't able to do all of those things, and then I get really worried about kind of that aspect of things where they're not going to be able to develop and learn in that way. The other one is, do they last a long time? So seizures have to last about 30 to 45 minutes before I have any concern of brain injury. And that's a really, really, really long time. And so in the moment, it feels, I'm sure, like 1 minute is about 30 minutes, but it takes a long time for there to be any risk of brain injury from a seizure. And that's because of the fact that the body does all of these things to try to protect it from having injury during the seizure. And then the other reason why we talk about seizures being dangerous and epilepsy being dangerous is SUDEP. And SUDEP is one of those things that nobody likes to talk about. We try to avoid talking about it at all costs, but there actually have been studies that have shown that when they ask families, do you want this to be discussed with you, the families overwhelmingly say yes. We do not want our doctor to hide this from us. We want to know that this exists. And the last thing you want to do is go have a very long neurologic appointment and then go home and start Googling and be like, why didn't my doctor tell me about this? So this is very rare. This does not happen frequently in pediatric patients, and it is usually in kids who have very hard to control epilepsy. We know that there are risk factors like tonic-clonic seizures, nighttime seizures, living alone, not taking your seizure medications, having uncontrolled epilepsy, and having really frequent seizures. So the best thing that we can do to prevent SUDEP is get seizures under control and keep medications in your system regularly. But other than that, there's not easy solutions for how best to avoid SUDEP, but that's why we do our best to keep seizures under control, because we want to avoid SUDEP at all costs. Seizure safety. Once again, you guys probably already know this, where most important things during a seizure, make sure you get someone safely to the ground. You just don't want them to fall and hurt themselves. Turn them on their side so that if they do kind of throw up or have saliva, it'll come out and not go down into their lungs. You want to time the seizure so you know when to give your rescue medication if you need to. And one of the things that I hear from a lot of families is that during a seizure, the thing that is the worst part of it is that commonly kids will get very dusky or turn blue around their hands and lips. And that's actually the body using its defense mechanisms that we talked about earlier, where it moves all the blood from everywhere else up to the brain so that the brain will have the energy to kind of sustain that long electrical activity, but it makes people look very, very ill during a seizure. It won't help in the moment, meaning you'll still see your kid looking that way, but it is what the body is supposed to be doing during a seizure to help prevent brain injury. Seizure precautions. So common things that we talk about, water safety, so shouldn't be taking baths by yourself, shouldn't be swimming by yourself. So whether it's beach, pool, lake, make sure that you're doing it in a safe way that someone could get you out of the water. Want to avoid high places if at all possible. You don't want to have a seizure and fall down. And then any other injuries. And this is where it gets tricky, and a lot of times I'll have talked with the family already about what does your child like to do for fun. Because this is where the hard part is figuring out what is this specific patient's kind of day-to-day life look like, where maybe they're at higher risk for injuries during seizures. I've taken care of 12-year-olds who do motocross biking and didn't think to ask, does your 12-year-old drive? Where you kind of have to understand what they do. And I've taken care of teenage girls who their goal for life was like high diving. And they wanted to they were going to go to college as high divers, and so we had to try to figure out how do we come up with a scenario to make that safe. And so it's hard to predict everything, but trying to think about what does day-to-day life look like and how can we make that as safe as possible. Other common problems that come up with epilepsy are going to be comorbidities of anxiety, depression, and learning issues. Anxiety and depression are so hard to treat in people with epilepsy because of the fact that we know that a lot of our seizure medications can cause these side effects, and so we're always kind of weighing, do we think this is a side effect from our seizure medication, or do we think this is an independent condition in and of itself that's causing problems? And so this is always something to make sure you're having really clear conversations with your doc about, because we know that this exists and we know that it's challenging. Learning issues also come up. We know they go hand in hand in epilepsy. They go hand in hand with the medications, anti-seizure medications. It is very, very hard for me to give you any specific guidance on this because it is extremely school district dependent and specific. Wherever you are, what resources are local change a lot state to state. And I've practiced in 3 different states now, and I can tell you they're completely different. So your local resources or kind of local chapters of epilepsy support are going to be your best places to go to. I know in Ohio, we're lucky enough to have Epilepsy Alliance of Ohio, who they'll actually go with families to IEP meetings if they need them to. So they'll kind of help advocate in those scenarios that if you're, don't quite know how to work with the school. Okay, treating epilepsy. So we have lots of anti-seizure medications. Probably at this point we have 25, 30 medications that we can choose from to try to get seizures under control. You have another lecture later today talking about the specifics of anti-seizure medications, so I'm not going to go into a lot of details, but I do want to talk a little bit about the fact that even though we have lots of anti-seizure medications, we've gotten better at making medications that have lower side effects, but our newer medications aren't particularly more effective than our older seizure medications. So we're getting better at better tolerated medications, but not more effective medications. And then probably the number one complaint I hear from families when I meet them as a second opinion is, my child kept having seizures and that doctor just kept throwing medications at them. And so I'm usually very, very specific with families when we start medications that there's a large dosing window of meds. So we usually start slowly over a couple of weeks and then get to the lowest effective possible dose of that medication. If it doesn't work, then we have to go up on the dose because we want to see if we get to middle of high ends of the dosing regimen, are we able to get seizures under control? But we don't start there because we want to avoid side effects if at all possible. And so that's the hard part, is that we start low to avoid side effects, but then our response is always going to be just go up on meds, just go up on meds, just go up on meds. And it's not ignoring the concern, it's just knowing that we've got more room to move on this medication. You'll also be prescribed rescue medications for most cases. And this, once again, is very state-specific, very school-specific, so I don't know exactly what's most common where you live, but there's intranasal midazolam, intranasal diazepam, rectal diazepam, and then oral clonazepam are all commonly used for rescue. Most of the time, we're treating for seizures longer than 5 minutes. Some places use 3 minutes, depending on where you are, or for clusters of seizures. Now, we pick this number because we know most seizures are going to end on their own in about 2 to 3 minutes. And so that's why if you get to 5 minutes, most likely you're going to need a medication to help make the seizure stop. And that's why that 3 to 5 minute window is there. We're still nowhere near that risk of brain injury, kind of around 30, 45 minutes. So I always remind families as well that in that moment, you're panicking, trying to get the medication, figure out what it is, run somewhere. If you're off by 30 seconds, a minute, it's not going to change the outcome. You're not causing brain injury. You're doing the best you can in kind of a chaotic situation. But that's something I want to take off the table as a concern when you're trying to give rescue. How long do we treat with anti-seizure medications? So the general rule of thumb is we like kids to be seizure-free on medications for about 2 years, and then we consider trying to wean them off. That's the case for about 70% of kids will be able to come off of medication after 2 years if they're seizure-free. Now, there was another study back in 2017, and that's this big rubric right here, where now we can actually individualize it by patient, and we can say, okay, what age did your seizure start? Did you have an epilepsy syndrome? What's your EEG look like? So we can try to get it even more detailed to figure out, can we fine-tune it for a specific patient? But what we understand is that really, if we get to the point where someone has probably about a 30-40% chance of seizure freedom coming off of medications, we usually try to get them off of medications if we can. But this is also a discussion with families, because I have some families who tell me, nope, I'm fine staying on another year. I never want to see my kid have another seizure again, and if we can wait one more year and chances are better, I'll do it then. I have other families who are like, I hate my kid on medications. I want them off medications as soon as possible. And so there I'm weighing the pros and cons and kind of what the family's priorities are for these kind of individual scenarios. Okay, so how successful are these medications? If we start off with 10 people who have epilepsy, we know that with the first medication, at least 4 of them will become seizure-free, maybe 5, depending on how we want to split the percentages. It really doesn't matter which medication we choose. As long as we pick a reasonable medication option, we're going to be successful in controlling seizures in about 40 to 50% of people. So that's why usually our first med is the one that we think will probably have the least amount of side effects and is easiest for somebody to take. By the time we try a second medication, we get maybe 2 more kids under control with our seizure medications. So there's still about 40% of kids who are still having regular seizures even after 2 medication trials. Once we go past that, so 3 medications up, we still get maybe like 1 more person seizure-free. So no matter how many medications we try, there's going to be about 30% of kids who are going to have drug-resistant epilepsy or kind of refractory or intractable epilepsy. And so our medications aren't perfect, but we can get 2/3 of people under control using them, which is why that's where we start. So what do we do when medications don't work? That's when we start thinking about other things like dietary therapy for epilepsy or surgical options for epilepsy. Dietary therapy is really thinking about kind of modified Atkins diet or ketogenic diet. Our body normally runs on carbohydrates. So basically our body all the things that we love to eat, pasta, breads, potatoes, get broken down into carbohydrates. That gets broken down to glucose in our bodies, and that goes up and powers our brain. They found out a long time ago that people with epilepsy would fast for a couple of days and their seizures would actually get better. So when we're fasting, what happens is we don't get those carbohydrates, and so we end up breaking down the fat we have stored, and that fat gets turned into ketones, and those ketones can go up and power the brain. And we know that when someone's on a ketogenic diet, those ketones are up there powering it, and we reduce seizure burden. Probably about 50 to 60% of people who try a ketogenic diet have about 50% reduction in their seizures, and there's about 10 to 20% of people who have almost complete seizure resolution when they go on one of these diets. Modified Atkins diet limits to about 15 to 20 grams of carbohydrates a day, so about the size of a small apple for the day. And classic ketogenic diet is about 2 grams of carbohydrates a day. It is really, really, really hard to do a classic ketogenic diet because, as you can see by the plate that's mostly oil, cheese, peanut butter, it's not the most palatable menu. Modified Atkins is a lot more tolerable. We do have to work with a dietitian when we do this because a lot of times we're restricting foods so much that we do want to monitor nutrition during this period. And I can almost guarantee you that if you go on a Modified Atkins diet, you're going to get some degree of constipation because I've pretty much eliminated all the fiber in your diet because you can't eat as many fruits and vegetables as you were before. But it is an effective therapy, and especially when I talk to people who are just over medication trials, we do especially kind of look at this as a possible option. Tends to work best in younger kids who have less ability to go get their own food and will pretty much just eat what their parents give them. I have had one teenager ever who has been successful on this diet, and she's a rock star, but I will tell you that she only did it because she really wanted to lose weight, and so that's why she was willing to change her diet. The epilepsy was just a bonus. Surgical options. So this is everyone's most terrifying topic to talk about because no one wants to think about having brain surgery. But it is sometimes one of our most successful options in getting seizures under control. So we have palliative surgeries for epilepsy with things like a corpus callosotomy, where we actually do a disconnect of the middle of the brain and kind of completely let mostly the right and the left side of the brain do their own things. It's a really terrifying surgery, but it's really effective with certain types of epilepsy, especially if someone's falling a lot with their seizures and injuring themselves. When we do this type of surgery, we can get pretty much complete resolution of their drop seizures, and it's pretty life-changing. There's neuromodulation options, which are devices that we can implant in the brain to help with seizures. This is an example of responsive neurostimulation, which is a device that's actually put in the skull, and it kind of detects when a seizure is occurring and then gives an electrical impulse to stop the seizure kind of in the moment. There's also kind of other devices like a vagus nerve stimulator that gets implanted in the chest and attached to the nerve in the neck. And then there's also DBS, which is deep brain stimulation. That's the newer device that we kind of adopted from people who we were using it in Parkinson's. And now we can target different areas or networks in the brain to try and reduce seizure burden. So there's a lot of new research coming out with kind of neuromodulation for people who aren't candidates for other types of surgeries. Additionally, there are some curative surgeries, meaning that if I can figure out exactly where your seizures are coming from, sometimes I can get my neurosurgery colleagues to actually cut that area of the brain out or disconnect it so that we can stop all the seizures. These are specific cases, but sometimes I might actually have a cure where surgeries that are bigger, like this hemispherotomy, where we disconnect a whole half of the brain, are successful 80 to 90% of the time in the correct candidates. In order to know whether someone is a candidate for this type of surgery or not, we have to get more data. So this is where, I don't know if any of you guys have gone through this before, but this is kind of the phase 1 epilepsy surgery evaluation, where we would bring you into the hospital, wean you off of seizure medications, try to capture the seizures that are going on so we can figure out exactly where they are and where they're coming from. We usually update brain imaging where we get an MRI. We sometimes can get a PET scan where we're looking at kind of the sugar uptake in the brain to see, is there one area that's not doing what it's supposed to do? We get a neuropsychology evaluation, because if we're thinking that everything's coming from the right side of your brain, we want to see, is that side of the brain working the way that it's supposed to, or is it also having trouble, to tell us that it's all that it really is where we think the seizures are coming from. And then there's a whole other slew of kind of fancy imaging studies that we can do, but this a lot of times depends on where you get the evaluation and where you get the workup, because different centers do it in different ways. And that's okay, because all the outcomes are roughly the same as long as somebody is doing it correctly with extra helpful studies. Okay, things you need to know about your neurologist. So I feel like these are topics that basically don't get talked about hardly at all, but just so you can know about your doctor. So all of us who are child neurologists did a child neurology residency, which means we did medical school, then 2 years of pediatrics, 6 to 12 months of adult neurology, and then 2 years of pediatric neurology. pretty much anybody who went through 2 years of pediatric neurology is going to be great at managing seizures. It's probably about 70% of what we do in child neurology residency. And child neurologists are absolutely amazing, awesome, and they're very, very good, especially if your child falls into the category of those first 1 to 2 medications are keeping things under control. But if you get to the point where a couple of the medications have failed, that's where there are recommendations to be evaluated by somebody who's a specialist in epilepsy or an epileptologist. And somebody who's an epileptologist right now can have training in either clinical neurophysiology, which means that they've done an extra year just kind of studying EEG, or training in epilepsy. And a lot of the reason why there's some discrepancies in this is because the epilepsy certification has only been around for about 5 to 10 years now. So older doctors a lot of times won't have that certification, and some of the training programs are set up. But either way, clinical neurophysiology and epilepsy are pretty equivalent for somebody being an epileptologist and having extra special training in epilepsy. And a lot of us will have done it even an extra year after that, specializing in just surgical epilepsies. So like in my training, I did a year of clinical neurophysiology and then went on and did a year where I just did only epilepsy surgery evaluations for a whole year, because it can be really hard to learn that without seeing large volumes of epilepsy surgery evaluations. In order to find people who are kind of like high-level epilepsy docs and centers who have high skill sets and do large volumes of epilepsy evaluations, you want to look for an epilepsy center. So there's a National Association of Epilepsy Centers that kind of actually accredits a lot of our big hospitals, and level 4 centers are the highest level center where pretty much they have skilled epilepsy physicians, they have geneticists, they have dietitians, they've kind of got the whole kit and caboodle to be able to do every evaluation that we need to for epilepsy. And the good news is that they're kind of spread all throughout the United States, so unless, unfortunately, you happen to live in kind of North Dakota, South Dakota, Montana, there are usually easy access to one of the higher level epilepsy centers, and if you go on the NAC website, you can actually just search for who's near you. But I would encourage that if you're in that category where epilepsy is uncontrolled, make sure you've been evaluated at a higher level epilepsy center, because they do have more resources to kind of know how best to help you and your child. Okay, that was my whirlwind pediatric epilepsy 101. So I tried to cover everything, but any questions about any of that? No. Go for it. So the question was about when I showed the picture of the EEG. So I'm going to go back.
It was one of those where, I think
Was it one of these or one of the EEG?
it was one of those.
Uh-huh.
It's like, was that the picture during the actual episode? Is that what the brain?
So yeah, so basically the idea is that the seizure might start in one area right here, and then it can spread to the other side of the brain. And so if it's spreading and it spreads to the whole brain, all you might see is just full body shaking. And so it would just look like a full body tonic-clonic seizure, but that could still be a focal seizure because it spread so quickly that you didn't see any other symptoms.
It's easy for that would be the same.
Mm-hmm. It would look exactly the same to you watching someone have a seizure. Yeah.
You mentioned that it takes 30 to 45 minutes for the seizure activity to affect the brain.
Yep.
Are there any other concerns before that? You said like the lips turn blue and everything, like suffocation, like anything you have concerns about?
No, usually, I mean, the hard part is that, so it's really, 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 really rare that somebody completely stops breathing during a seizure. There's a few rare types of epilepsy that can have that happen, but most of the time what happens is that during the seizure, chest wall gets really tight, and so you just can't see breathing during that period. So typically we don't need to do anything as long as there is still some air movement. Occasionally in those rare situations where we feel like people are stopping breathing, we'll have families give rescue medication earlier in the course of the seizure, but that's definitely the rarity. Most of the time it's just that they're still making good kind of oxygen exchange. It's just that it looks horrible to watch someone have it. Mm-hmm.
And they're pretty bad, like fever for that. He has an ENS, they're all on some kind of cocktail.
Mm-hmm.
Have you noticed that, is there any specific medication or procedure
one of the problems we have is, especially when we get to some of the rarer genetic epilepsies, there's just not robust data to guide us. And so that's where, number one, you think about 10, 20 years ago, we weren't doing genetic evaluations on everybody all the time. Whereas nowadays, like at least in our hospital, if you come in for an epilepsy surgery evaluation, we actually get genetic testing on everyone as part of our initial screening process, because we just say this is the time we want to make sure we're not missing something else. So I think that as time goes on, we're going to get larger and larger patient volumes to be able to start seeing patterns of how people respond to different seizure medications, but we're still in the gathering information stage. And so you end up with a lot of families who talk to each other and just say, what worked for your kid, what worked for, and kind of passing things back and forth. And that's the hard part about with some of those rare epilepsy, genetic epilepsies.
Yes. The VNS has worked for him, but like, with her, they haven't like gotten to that yet.
Yeah.
But like, so we're just like going through all of the different medications.
Yeah. No, it's a tough journey. Yeah. So the hardest part is that there are lots of events that look like seizure but aren't seizure. And so, once again, it depends on your child and what's going on, but that's where it can be helpful to try to figure out if they're daydreaming or if they are having one of these other events and they snap out of it. There are other neurologic diagnoses that go along with funny movements, staring unresponsiveness. And so if you're pinching them and they completely snap out of it, that makes me a lot less concerned for seizure, because you shouldn't be able to completely get them out of something just by pinching them. And so that's where I get a little bit kind of, it doesn't work 100% of the time, but it makes me more suspicious and makes me want to make 100% sure that these are seizures. And it comes up really commonly in especially kids who have a known diagnosis of epilepsy, but also do other funny things. And then we're trying to figure out, are these other funny things seizures or not? Because we want to know if they are, but I also don't want to go up on their anti-seizure medications if I'm just treating them having behavioral movements or things like that. Yeah. Mm-hmm.
And she'll be out.
Yeah. Yeah.
And that's what the she's like. And the doctor wants to take her out of medicine. She's been running seizure for 3 years.
Mm-hmm.
But it's she still has like some movement in the head sometimes.
Mm-hmm.
And she'll be like, I see spots, and then she just
Yeah.
hear me. And I'm like, and I told the doctor, it's like, well,
And it's not an uncommon situation where then we have some new event and we're not sure what it is. And especially if it's not happening frequently enough where we can bring you in the hospital for 2 days and capture it, we get stuck in this in-between where we say, do we go up on meds and see if it goes away? Do we go down on meds and see if it gets worse? And sometimes that's the only option we have when something's infrequent, is to basically, for lack of a better term, use your child as like a medication, kind of a little bit of a guinea pig to figure out what's working and what's not. Because if it's infrequent, I just don't have a better test to figure it out. And that's the frustrating part. And this is where a lot of times if I'm stuck in this situation with a family, we'll talk about what do they prefer. Would they rather go up on meds or rather go down on meds? Yeah. So the question was kind of seizures changing over time. And so there's a couple different reasons why that can happen. One can be, especially if you're someone who has bigger seizures and we start you on medication and then all of a sudden the seizures change, like where they're just staring at unresponsiveness. My suspicion would be is that you're someone who probably has seizures starting in one area that we're spreading to the rest of the brain, we put you on medication, and now they can't spread as far, so we're just getting a smaller version of the same big seizure. So, because that's what the seizure medication is doing, is preventing that electrical activity from spreading throughout the brain. The other issue may be, too, we know that epilepsy can change over time, especially kind of as you get hormonal changes. And so it may be, too, that as you go through different developmental periods, seizures can look a little bit different, especially kind of as the brain develops. Because there can be some other tricky parts too, like we talked about the brain having kind of being wires going one place to another. What happens is that as kids get older, they actually kind of like insulate those wires, and that's what the white matter is in the brain, is kind of insulation of those wires. So sometimes as they get better insulated wires, that electrical activity can actually spread better in the brain and spread to different places because their brain is developing, and so now there's new pathways or new ways to go with the seizure. But it's hard to know without knowing all the details, but usually it's either development, changes in medication, or sometimes epilepsy itself just changes over time. Sure. My best guess would be that there was a predisposition to seizures, and especially based on kind of how old you look, it may be that kind of going through puberty is what changed everything, because we know that going through puberty can change epilepsy, but it's the least helpful description ever, because about a third of kids get better, a third of kids get worse, and a third of kids stay the same when they go through puberty. So all I know is that it changes things, but I can never predict who's going to get better, who's going to get worse. But that would be my kind of gut instinct without knowing all the details. Yeah. So the EEG can capture seizures that, a lot of times we'll see where, especially if kids have multiple different seizure types or things like that, sometimes we will capture subtle seizures on EEG that family hasn't seen at home, or they just thought it was their kid doing normal, funny movements, because kids do weird things. But then when we get captured on EEG, we can say, oh, we do think that this is this specific type of seizure. But usually in those situations, we'd like to get it on video at least if he was in the hospital, so that we could say, oh, this is what it looks like. And that'd be an opportunity too where we could kind of go over it together and say, oh, this is what it looks like. And a lot of times when you do that, the parent will say, oh, I have seen that at home. I just didn't realize that was a seizure. He's been doing that for a while. So it's usually, we can just capture it on EEG even if you haven't seen it at home. But usually, if we go through it in detail, most families would be like, oh, I've seen that before, and I just thought it was nothing. It may be with the, so sometimes what can, at least the nose wiping is one of those classic features of seizure, because what happens is that basically you can sometimes get autonomic features with seizures where you get a little nose running. And it's actually one of the things we teach our trainees, because after a seizure, they'll actually wipe their nose, and that can help us decide which side the seizure came from. But I have to stop now because I see the next person in line to give their, oh, no, I'm good? Okay. Yeah.
When you said that if they're seizure-free for 2 years and they come off the medications, what's the typical maintenance, or do they get yearly EEGs? Because if they go through adolescence or adulthood, is there risk for returning?
Yes. It depends a little bit on the type of epilepsy, but I usually operate under the premise of I don't go looking for trouble. Because we know that the EEG doesn't always normalize, even if somebody's seizures go away. And if your child has been seizure-free for 2 years, doing great, and then we get an EEG and I say, well, it's still abnormal, nobody feels great knowing that the EEG is still abnormal. I just would say, yep, EEG is still abnormal, go do your thing. And so I usually just don't get the EEG because if it's not going to change what I do, I don't want to put a child through the EEG. And I also, like I said, I don't go looking for trouble if things are going well. The one little difference to that would be maybe if you're dealing with a teenager and driving's on the table, I'm a little bit more rigid in looking for seizures, but that's probably that's a very unique scenario.